Today they have organized one BPNI lecture at 3 o'clock.
Yes, ma'am.
In India, I
Two,
tried.
three events are there today.
Huh?
Two, three events are there like that
Yeah.
today.
Actually, I tried to convey to them because, it's at 3 to 4. And the audience for that talk and our talk will be.
Similar.
So I said, is it possible to change? But it was already communicated. So it's not possible.
Lot of overlap of events are happening now.
Yeah.
Yes.
So actually, theirs is not a day specific. Now we can't change the day, but that talk could have been on the different day.
Yes, yes,
Yeah,
yes.
but
Now, they must have wanted to keep it on this day, particular day, when they plan.
but there is nothing, related to KMC directly in that
I
topic.
know, I know, I know.
So anyway,
I think, Amit, let's start. 2:30.
Yes,
Yeah,
sir.
yeah, yeah.
So, welcome everybody for this wonderful webinar on a very important topic, kangaroo mother care. And we have a wonderful team with us, the most senior members who are actively involved not only in just KMC but into IKMC, which is immediate KMC to be given soon after birth. It has been shown that such zero separation policy or close to zero separation policy of baby and mother has tremendous effects on outcomes of neonatal mortality, hypothermia, and also maternal satisfaction. So, with this background, I would request our president, Dr. Manoj VC sir, to please welcome all the guests and begin the session.
Respected doyens of neonatology and the topic for today, Kangaroo Mother Care, Professor Shashivani, Professor Kumudak, Professor Ruji Nanavati, and all other respected seniors and my dear friends. Warm greetings from National Neonatology Forum. We all know today is a very special day for all of us. We honor today the simple yet powerful act of love that makes the world a difference in any newborn's life. KMC is more than a method, it's a lifeline which we should offer. The sicker the babies are, they need it more. It is one of the primary prevention strategies in well babies as well. So there is no reason why if you take care of newborn babies, you don't offer kangaroo mother care, or rather IKMC, start with IKMC, zero separation at birth, and then go on as a lifeline. We all know the skin-to-skin contact, warmth, and heartbeat of a parent, fragile lives, gain strength, stability, and stronger chances. All these benefits are known to us, but there is more than that, which we need to realize. We realize we are going back to the ways the nature has intended newborns to be taken care of. So friends, this is a reminder. Today is a reminder of the critical role that nurturing touch and closeness and warmth play in neonatal care. Let us all appreciate the dedication of all our doyens of neonatology down to all the healthcare providers, the courage of the parents, and the resilience of tiny fingers who benefit from kangaroo mother care every day. So let us resolve today to continue to raise awareness and promote this life-saving practice, ensuring every baby, regardless of birth weight or circumstance, gets the care, warmth, and connection they deserve. Let us celebrate this happy Kangaroo Mother Care Day with a resolve to promote it more and more. Thank you. Over to you, Amit.
So we have our moderator, Dr. Ruchi Nanavati, madam. And I invite Dr. Ruchi Nanavati, ma'am, to please initiate the proceedings and invite our faculty who are there for lectures.
Uh, Thank you, Dr. Manoj and Dr. Amit. Now, as all of us know, today we are here to celebrate International Kangaroo Mother Care Awareness Day. And we all here are, the KMC supporters, KMC promoters, KMC champions. And on this particular day, 15th May, it brings the international community together to promote, support, protect KMC, to share our success stories, and also celebrate KMC and to plan for the future. How can we further enhance KMC? And this year's theme is In My Arms You Thrive. And when I look at this theme, you almost feel that it comes from your heart and actually captures the essence of KMC. As Manoj has said, this is simple but yet very powerful, strong theme, and that highlights the impact how parents embrace their baby, and it goes, for the well-being of the child, growth of the baby, and healing of the child. It recognizes also, this theme tells us that what is our responsibility as healthcare workers, that how do we promote KMC. And just few lines that if we look at newborn statistics in world, every year 19.8 means almost 20 million babies are born as low birth weight. And in India, we have 4.32 million babies which are born low birth weight. If we look at the world, the preterm babies are 13.4 million preterm babies are born in the world, and India accounts for about 22%. So we have almost 3 million babies which are born as preterm in India. And as we know, the statistics which was shown in 2020, that 45% of all preterm births occurred in 5 countries: India, Pakistan, Nigeria, China, and Ethiopia. And that's why, looking at the quantum of this and the essence of care of these babies, the Lancet described a new term called as small vulnerable newborns, and it includes the babies which are born too soon, that is preterm babies, the babies which are born too small, that is SGA babies, and the babies which are born too soon and too early, that both they are preterm and SGA, and they contribute to more than 99.5% of total low birth weight babies born in the world. And another important thing, that more than 55% of causes for neonatal death occurs in this particular population of small vulnerable newborn. And that's why we require to promote KMC, which we say fondly as the hug that heals. The Kangaroo Mother Care is a hug that heals and helps the baby for the better growth and development. So if we work on this as a community all over the world, doctors, nurses, parents, and community, then we'll probably have this last mile we have to reach our sustainable developmental goal of single digit NMR by the year 2030. So I think we have a very interesting topic today, looking at zero separation, immediate KMC and MNCU. And to discuss all these topics, we have very, the knowledgeable and the experienced group of faculties and senior people from India. And the best person to start this is Dr. Shashivani, who is a mother of KMC in India. And I request Madam to share her feelings and share her insights on how do we achieve zero separation, what is the importance, and guide all of us on this topic. I request Dr. Shashivani to start. Thank you, Madam.
Thank you very much. Can we have the slides from there, Amit?
Yes, Dr. Debaru.
Yeah. First of all, I'm really happy that day by day acceptance of Kangaroo Mother Care is increasing in our country. But unless we reach at least minimum of 90% coverage, all the impact will not be felt. And every day we are having one more step to go. Earlier, we just started with the saying that kangaroo mother care is skin-to-skin contact. Then we realized it is skin-to-skin contact on mother's chest. Then we realized it is not only the kangaroo position, but it also includes kangaroo nutrition, that is promotion of early and exclusive breast milk feeding, even in this group of highly vulnerable groups. And now we have realized one more step, that we have to bring these babies and mothers together to get more benefits. From mere survival of the babies with the help of machines and mechanics, now we want to go towards well thriving of these babies with good quality survival, good behavior, good mental development, and all the requirements for a good life. So from that angle, the recent development of concepts of zero separation and immediate kangaroo mother care, even for the small and sick newborns, gains an important. We are emphasizing on small and sick neonates because these are the babies who are, with all our good intentions, we have been separating them from mother many times as soon as the baby is born. As one of the very senior person put it, already there is an insult of being born too soon, being born too small, and with several complications which are inherent with the preterm and low birth weight babies. And we are adding to the problem by separating these babies from their mothers. And now there is enough evidence to show that keeping the babies and mothers together as early as possible, we can gain many things. Next slide, please. And this, when our foundation was initiated, actually we started working since almost 3 decades. But formally, when we crystallized our mission statement, right at that time, we had included zero separation of mother and her baby in our mission statement. This we learned from Dr. Niels Bergman, who had come here for our international KMC conference, and he gave a beautiful justification for this statement and for this concept. And from that, we have said that, of course, our mission statement is mother's chest is the best place for the newborn care. Mother's milk is the best food for the newborn, and zero separation of mother and her baby. And of course, KMC is meant for all the babies, but it has got special benefits for this highly vulnerable group. So from that angle also, we have to realize that zero separation concept, which was realized almost 2 decades ago, now we are realizing much more significance to it with internationally generated evidence for it through WHO and support from WHO. Next. Next slide, please. As I already put, only the machines will not help the babies for thriving well. They can help us for surviving, but with well-being, good intelligence, love, and good quality of life, the input of mother is required. And wherever mother is not possible, at least for some time, surrogates can help us. And survival of the newborn should be an asset and not a liability to the society and nation. And now we have found with the help of machines, we are able to survive the babies, but many times they are liable in many ways. Next. So thereby, we are now trying to bring out our old natural method of taking care of the babies. So our current method of care of the small and sick babies and even normal newborns sometimes is based on routine separation of baby from mother. Say, for example, if the baby is born of cesarean, just for observation, we take them. If the baby is of meconium aspiration, we take them for observation. If the babies are twins, so even if there are no complications, we have now the tendency to separate the mother and baby as early as possible, and that is not justified. So the new knowledge does not justify this separation and makes a strong case for zero separation. And why this zero separation is having some scientific basis also. It is not just an emotional outburst, but it has a scientific basis. and we are trying to understand that. Next. So as I already mentioned, Dr. Niels Bergman, who was earlier working in South Africa and now he is in Sweden, a strong champion of kangaroo mother care and a serious researcher, he has coined this term zero separation. And thereby he mentions that it minimizes or eliminating any unnecessary separation between the mother and the baby immediately after birth and for as long as possible, and particularly even in the case of premature and very premature babies, where very often we justify this separation. So this diluted justification, we want to make it as rational as possible with our better understanding. Next. So as I already mentioned, with all our good intentions, we tried to put the babies under the mechanical gadgets to give them a womb-like atmosphere, giving them the warmth, giving them the oxygen, giving them the fluids, nutrition and all. But then we found that these babies, when they survived, they had many problems. Next. And then we tried several other ways also to give a womb-like environment to the baby following the separation from the mother. But now we found many times, most of the times, we are able to keep the babies on mother itself. And we can minimize this separation as much as possible. Next. Next, please. So, zero separation has a scientific rationale, and that justifies that maternal sensory inputs are mandatory for neonatal homeostasis. They regulate the baby's temperature, stabilize their heart rate and breathing even earlier, and promote breastfeeding and strengthen the emotional bonding. And it is the biologically normal place for the development. Next. The same thing we are going to repeat, but again we are justifying that in our anxiety to give a womb-like care to the preterm babies, we give them the technology-based NICU-based care. But now we have realized very times it is a poor substitute for the womb. So the natural KMC environment is essential for optimum neuroprotection and neurodevelopment. Many scientists for the past 2 decades have brought this concept very rationalized with their experiments and the justifications. Next. So this is also well known that we have developed developmentally supportive care, that when the baby is in incubator, naturally it is exposed to several noxious stimuli, which has got stressful influence on the body and the brain of the baby, and baby feels unsafe. So naturally baby tries to conserve its energy by extra expenditure and so on. Next. So this stressful influence on the developing brain, that has found to be one of the major influencer. And that stress also, scientists have tried to grade them. Positive stress, tolerable stress, and toxic stress. Positive stress, next one, which every baby almost undergoes, and it to some extent for a healthy development, it is required, even for a context of stable and supportive relationship. So it may be just any discomfort, external stimuli, tiredness, hunger, thirst, and so on. And this is required to some extent to stimulate the development of the baby. Next. And now comes the stage of tolerable stress. There for some time, we have to separate the baby. So there is an absence of mother, painful procedures are being done, harsh lighting, all these external noxious stimuli are there. But if they are for short time, yes, there are certain changes in the brain, but there is an opportunity to recover from the potentially damaging effects. Third level of the stress, which is toxic stress. Next level, please. Next slide, please. So this is the one which is really very much worrying to us. Strong and prolonged activation of the body's stress management systems in the absence of the buffering protection of the adult support. they have put it very clearly that they have long-standing effect on the brain. Next. And this is important because the two babies are born too small, too young, and they are sick. They are the ones whom we keep them in NICUs. They are the ones whom we separate from the baby mother as early as possible and as long as possible. And this is where the brain is very immature and very easily vulnerable for multiple toxic stress responses and vulnerable for the cumulative physical and mental health effects which last sometimes even for a lifetime. So many of the current physical and mental health problems, maybe we can have this answer in the early closeness of the mother and baby being kept together. And this mother's being together with the baby gives so many buffering effect to the baby. Next. And they have studied that the persistent stress changes the brain architecture and which is responsible for many of the adverse events. Next. And animal experiments also have proved that when the mother-infant separation has occurred in the research on the rats, it has given so many adverse effects which may be comparable to the baby who is kept in the incubator, separated from the baby, where the crying is increased, the activity is increased, the growth hormone is diminished, cortisol levels are increased, sleep cycles are disrupted, arousals are more, less of quiet sleep, and all these have adverse effect on the brain development, not only temporarily, but sometimes may have irreversible long-term damage on the brain also. And there are number of studies today. Because of the time limit, I am not able to quote, but there are a number of studies justifying all these statements. Next. And another important point is, this is the basic thing, that in the brain architecture and cell development, hierarchically, there is a bottom-up sequence. Whatever the skills developed in the beginning, they may be very basic ones, but if they are strong, on that, the further complicated skills can be developed. So that is another point which justifies that the babies as early as possible should be given the buffer so that their basic skills are developed well. Next. So another aspect they have brought out, this is also from Dr. Niels Bergman I am quoting, that babies who are separated from the mothers, they cry more. And modern neuroscience does not approve this cry. The cry reduces the level of growth hormone and increases the level of cortisol secretion. And that cortisol enables survival at the cost of extra energy spending. That means the baby's limited energy stores are spent for the protection level. And that increases the energy demand, hypoglycemia, which again has effect on the brain development and so on. And these non-separated babies, the energy is conserved and available for the development. Another aspect, cry is one aspect. Then separated babies, their quiet sleep is reduced. And during the sleep only we know several sensory developments and the brain developments, they are occurring. And if the sleep is disturbed, naturally the whole developmental pattern is disturbed. Then the autonomic pattern is also severely threatened and many adverse reactions are there. So zero separation is biologically normal and improves the quality of survival. Yes, with today's limited, today's available knowledge, we realize when the baby is critically ill, life-saving interventions have to be done, multiple interventions have to be done. Naturally, we have to separate the babies at least for some time, but we have to think of all the situations whereby again we can bring the baby back. For example, suppose the baby had severe respiratory distress, we had to start the baby, say, on CPAP or mechanical ventilation. But once the baby is stabilized, or at least when the whole system is put well, instead of keeping the baby under the warmer, you can keep the baby on mother's chest. Like that, you can try to find out how early you can bring the baby and back and minimize the separation. Next. So that is exactly what is given when the baby is on mother's chest. Familiar heartbeat is there, reassuring voice of mother is there, soothing contact and touch is there, baby feels safe. And when the baby is feeling safe, body also comes, brain also comes, and immediate and long-term advantages are there, and so many benefits are there. Next. And when breastfeeding is also immediate early breastfeeding is promoted, it also adds to several other advantages. Next. So non-separation is the most appropriate developmentally supportive care model, at least as on today, and it stands to reason and common sense that mother and baby together, naturally they have got many advantages. There were certain anxieties when the baby is very sick, and if we include mother during that care, whether the mother's psychology is affected, mother will be affected. But now the studies have shown that even mothers, very few mothers cannot stand, but majority of the mothers, they would rather like to be with their babies, even when the baby is sick and being handled for multiple interventions, rather than separated outside and having anxious moments. So being with mother and skin to skin contact, infant's brain is working in safe mode. Yes, we accept. And the same thing which I already said, it helps in the promotion of optimal development and functioning, increase the preventing of the pain, prevents intensive stress, but and prevents depression due to separation with the baby. But mother also has got several advantages, even when she is involved in the care of her sick baby. Because sometimes I myself had the doubt whether the mother can see her baby is being given so many breaks, the baby is being given so many interventions, whether her psychology will be affected. But to answer my questions, there have been some studies justifying that mothers or parents would rather like to be involved or at least witness what is being done for their babies rather than being away. Next. Next, please. So we know the benefits which are given due to skin contact on oxytocin. Here I would like to mention one more thing. Skin to skin contact, when we mention, again, it has to be qualified that it should be on the chest. Because on the chest, there is a different vascularity pattern and the oxytocin production is maximum and the benefits are maximum. The skin contact, suppose you attach the baby on your cheek while giving kiss, or you attach the baby on tummy when you are feeding the baby or handling the baby, the effect may be not that much as it is on the mother's chest. There are studies justifying this statement also. Next. So impact of separation, same thing which I already mentioned, that maternal sensory inputs that regulate the physiology of the newborn, they are not there, and that separation causes harmful effects of dysregulation and subsequent epigenetic changes. So ultimately, we are coming to the same conclusion that mother's body is biologically the normal place of care for the babies. Next. Same thing has been agreed by Dr. Ewald, even from Sweden also, way back in 2015, that the new place of care for the premature infant is the chest of his or her parents. And subsequently, they have now justified that even for this, not only the premature, but very premature infant, sick infant also, it is the best place for the care. Next. And there are so many advantages. We start the zero separation by starting with the immediate skin to skin contact on mother's chest soon after birth, except for those babies who require urgent, immediate, advanced resuscitation, or those babies who have severe shock and other interventions, any life-threatening urgent interventions where they have to be separated from the mother. All the other babies, they should start their journey on mother's chest. And there are so many advantages. One is, of course, the major advantage is in the breastfeeding, early initiation of breast milk feeding and breast milk secretion, easy latching and others. Next one. And there are other advantages also that early stabilize. Next slide, please. So the bonding is there, mother and baby are relaxed, less cry and so on. The same things which I have been telling earlier. So all these are justified. So we start our baby's journey by putting the baby even before cutting the cord on mother's abdomen or chest, depending on the length of the cord. Keep the baby there for at least 1 to 3 minutes. Delayed cord cutting, quickly dry the baby and transfer the baby on mother's chest and continue further care. And wherever severe life-threatening interventions are required, minimum time to be taken to separate the baby from the mother and then try to shift the baby again on the mother's chest as early as possible. And from there on, as much as possible, do not try to separate. You transport the baby also from the labor room to postnatal wards and wherever possible, even during procedures, even during medical interventions, injections, all those things. So that aspect, our other speakers will be telling you. So I'm not telling. So we try to minimize baby and mother separation, and there are so many scientific justifications. Next one, please. So why promote KMC in NICU? Because NICU is the place where these babies are there. Very preterm babies, very sick babies, very low birth weight babies. So naturally, their care should start from there also. Means we start the care right from the delivery room, then transport them with the mother. Even in the cesarean babies also, we start KMC in the as early as possible, ideally soon after birth, and then transfer the baby, or wherever possible or required, absolutely required, you keep the surrogates also for them. And subsequently, you continue even in NICU also zero separation. And for that, now the concept is developing that you admit the mother herself in the NICUs so that she will help us to provide prolonged KMC, almost 24 hours KMC to her baby with all the procedures and with all the treatment modalities. Next. And recently, WHO has also recommended the same. Earlier, WHO was recommending that we start KMC for stable babies. Then we said stabilize babies with oxygen, IV therapy, tube feeding, and so on. And now we are saying even for the sick babies. And WHO study, international study, has given full justification for this concept of immediate KMC. That is, even for the highly vulnerable preterm sick babies also, judge your capacity, judge your facilities, and develop the policies to start KMC as early as possible, preferably within 2 hours. Ideally, soon after birth, but if due to some reason you had to postpone it, but try to make it within 2 hours and continue so on. And our next speaker will be talking to you about that experiment more. So I'm not saying, all that I'm saying is KMC for preterm and low birth weight infants also should be started as soon as possible after birth, and it should be continued. And for that continuation, the NICU policy should help us. Next. So recent focus of Kangaroo mother care in government programs also, they are now trying to include the concept of zero separation, which is initiated through immediate skin-to-skin contact on mother's chest soon after birth, continued through immediate KMC and mother and newborn care unit, nurturing care for the newborns, developmentally supportive care, and family participatory care. So all these are now being integrated, and They are combined with KMC, and even when the baby is not in KMC, the nurturing care and developmentally supportive care should be offered to the baby. So these are all the recent developments, and hopefully they are for the good, and I'm sure they have a lot of impact on the future development of the baby. Next, please. So, if possible, no baby should be separated from their mother. And if there is separation, introduce skin to skin contact on chest as soon as possible and as often as possible. So it is huge disservice to mothers when their newborns are separated from them. And not only for the mothers, even for the babies, because they cannot speak, they cannot express, but it is obvious that babies also suffer a lot when they are separated from their cozy environment. Thank you. Cozy, loving environment. Thank you very much. Next. Thank you. Bye.
Wow, that was a wonderful lecture, ma'am. And so much information about KMC, so much evidence about KMC was produced. But the best was that mother's chest is the best place for the baby. Mother's milk is the best milk for the baby.
And zero
And,
separation.
and zero separation of baby and mother. And you really presented a very strong case for zero separation of baby and mother in your talk today. So, any, I think we can take the questions or comments later on, ma'am.
Yes.
So, after this wonderful talk, I would request Professor Sugandha Arya to please present her talk on IKMC. She is one of the doyens of Kangaroo Mother Care and immediate KMC. She did one of the biggest trials, uh, which was sponsored by WHO from Safdarjung Hospital. She is the in charge of NICU care at Safdarjung Hospital. And I would like to invite Dr. Sugandha Arya to give evidence for IKMC, that is immediate KMC, and also tell art of creating maternal and neonatal ICU. That is together, it's not just NICU, but it is mother and newborn care unit and perspective of pediatrician. If she could initially tell perspective of the pediatrician for that. There are a lot of concerns which pediatricians have if both mother and newborns are there all the time, that there would be, medical legal issues would be there. There will be interference. Mother may not, understand what the nurses are doing, and they may interfere with the work. But all these anxieties have been allayed by a lot of studies led by Professor Harish Chilani sir, who we are missing today because he was engaged in another very important lecture he had to attend. And myself and Sugandha are not just friends on KMC, but also we are batchmates and students of Dr. Harish Chilani from Safdarjung Hospital. And so with that, I would like to invite Dr. Sugandha Arya for her talk.
Thank you, Dr. Amit, for introduction. Can I share my screen now? Presentation. It's a fully new year. Next one. मैं तो ना खोल के मिनिमाइज कर देती हूँ तो इमीडिएटली आ जाता है. Is the presentation visible?
Yes.
Yeah. Okay. Thank you, ma'am. Actually, Dr. Shashivani has set the stage so well that during her presentation, I was thinking that why this even trial was required to produce evidence of immediate KMC. This was all proven and all already known by the science. So actually, this such kind of trial, the results were already expected and was probably not required even. But this gave us a robust evidence. So I'll just go through a brief to make you how this trial happened. And this trial only taught how to create MNCU, which they gave me mandate to do. So how we made it that time by having different kind of arrangements or how the things can happen. So this is how we learned during the trial and then replicated that. This Dr. Ruchi Nanavati has already stressed upon that if we want to dent neonatal mortality, SDG goal we need to achieve, we have to look at the low birth weight mortality. They are the major contributors. And among those low birth weight babies, for preterms and IUGRs both, we have the major interventions, known interventions, which are very, very effective interventions. 75% of neonatal mortality is preventable. And the major interventions which can prevent neonatal mortality for preterms, antenatal steroids, kangaroo mother care, breastfeeding, and CPAP. These are the 4 very effective known interventions. However, unfortunately, the coverage is pretty low and not making a dent. So in 2015, I will be among these interventions, KMC breastfeeding go hand in hand. And regarding KMC and breastfeeding, in 2015, wherever the world was regarding KMC, we all knew that KMC improves survival by Cochrane analysis. 60% mortality can be reduced by KMC. 40% mortality can be reduced by KMC. And it was known for 2 decades. WHO has been recommending KMC for 2 decades, and we all know about KMC, but ma'am was telling much of it is known for decades now. If you look at those studies which Dr. Shashivani ma'am was presenting, some of them dates back to 2000s, early 2000s. However, the global KMC coverage is very low, less than 5%, and after all these efforts, it is still very low, including India. So there was an issue, if KMC is so effective, 40% mortality can be reduced, why the coverage is not happening? So that was a major question troubling every one of us and wanted a solution. Second thing was that KMC can be initiated in hospitals only. So what happens to the community born babies? And Dr. Shashivani ma'am has a huge experience even before this study that how in the community KMC help out when the babies cannot be taken to the hospitals or KMC has not been initiated in the hospital. But here what I'm going to talk about IKMC trial was about the question that does KMC initiated immediately after birth save more lives? I'll tell you why this question arose in little more detail, why this trial was required. As I showed you, Cochrane meta-analysis showed that mortality can be reduced by 40% by doing KMC. But if you look at in detail the studies which were included in Cochrane, the mean age of randomization of the babies in Cochrane was around 3 days or 72 hours. Some babies randomized at 10 hours and some as late as 24 days. But we all know most of the preterm deaths, 75% deaths happen in the first week of life and 50% in first 24 hours. It means majority of preterm deaths actually happen even before the baby was eligible for KMC as per previous guidelines. It means the reduction in mortality which we are talking is actually among those babies who have survived the initial period. Those who have died. Among those who survive and become stable, you can prevent so many deaths in them. So what can we do about the babies who have actually died before KMC was initiated? So this research question, came up. If we start KMC immediately after birth, that is immediate KMC, and then compare it with the KMC as per the guidelines of that time, 2014, that KMC only after stabilization, do we save more babies in addition to what we are already saving by KMC? Before this trial was started, there was a lot of apprehension for the safety of this intervention. And by that time, there was a very little literature with us. 2 small studies in Vietnam and South Africa were done, which showed that skin-to-skin contact starting after birth, even in sick babies, is pretty safe. They were not efficacy studies, but it is quite feasible and safe. And on this background, IKMC trial was built up. This IKMC trial, immediate KMC trial, was done in 5 countries: Ghana, Nigeria, India, Tanzania, and Malawi. And in these 5 countries, it was coordinated as by WHO, it was told, and intervention support was given by Sweden and Norway because these are the 2 countries which were already practicing this intervention even before the IKMC trial. So this trial was I'll tell you a little brief about the trial so that you understand how this evidence built up, the evidence of IKMC, and then we come to how we implement it by creating MNCUs. I'll come in the second part of my presentation. So IKMC trial was a randomized control trial, and the babies who were mothers who were enrolled in this study were 1 to 1.8 kg, because we all know in most of the countries, including India, all babies less than 1.8 kg, sick or whatever you take definition of sickness, all babies less than 1.8 kg, even if no complication, they land up in SNCUs or NICUs, and they're all, and that is an indication to admit them and separate them from their mothers. All the babies less than 1.8 are separated, irrespective of the level of sickness. So in those, this study was done. Intervention, as I told you, that KMC to be started soon after birth without waiting for stabilization, and control was standard of care as recommended at that time. So the intervention group, what will happen if a baby born 1 to 1.8 kg and consent taken, and they will be randomized by envelope, and if he lands up in intervention group, the KMC will be started in the delivery area, either this OT or cesarean section, or in the labor room after the vaginal delivery. The baby transported with mother/surrogate to MNCU in KMC, and then KMC continued in MNCU. I'll tell you, now the MNCU term has got introduced, and ultimately the baby will go to KMC ward, just like the other babies control group who go to NICU. So the baby is born 1 to 1.8 kg, he gets into control group, he gets separated from the mother goes to the post-baby ward, baby goes to NICU, conventional NICU, and when he starts recovering, mother starts visiting for brief sessions of KMC, and once stable, both these groups meet in the KMC ward. Inclusion criteria in this trial, the baby is 1 to 1.8 kg, as I told you. And a very important thing that in this trial, twins and cesarean section babies were included because they account our 25 to 30% of our deliveries are by cesarean, and near 20 to 25% of twins. So to have a generalizability, so after the trial we can say this is applicable to twins also, and this is applicable to cesareans also. Exclusions were those cases where either the baby required level 3 care, which was not included in this, or mother had some problems where mother could not come to MNCU within next 3 days or 72 hours. In those cases, we excluded those mothers, or KMC was not possible due to some congenital malformation. So the intervention, which was named as immediate KMC, was that you start KMC immediately after birth, at least try within 2 hours of birth, and then give it throughout the day after that continuously, even if the baby is going to NICU. And in the trial, baby required NICU because the baby is less than 1.8. Exclusive breastfeeding, we know that it is an integral component of KMC, but the most difficult component of this intervention was providing medical care for the mother and the baby in skin to skin without separating as much as possible. Because baby is sick, mother has just delivered, and maternal care will be taken care in the next session. So now to operationalize immediate KMC, if you say baby, as Shashivani ma'am said, the baby put on skin to skin at birth, which is for every baby, not only for low birth weight. This is a recommendation for every baby who got clamping. But if the baby is less than 2.5 kg now, or in the trial 1.1 to 1.8, this baby will be started in KMC in the delivery area, transported in KMC, shifted to MNCU, and then finally after stabilization KMC ward or step down ward. So what this is looking like, this is nothing but zero separation. So these terminologies are actually very overlapping and mean the same thing, just the mother baby together. Right from the birth till discharge, that is a zero separation. So as I told you, the babies who receive immediate KMC or in the trial, as we did on our recommendation that less than 2.5 kg babies should be started in KMC delivery area, transported to the MNCU or NICU in whatever is possible now in KMC position. Now coming to the mother newborn care unit concept, how this got created. Actually, IKMC trial gave birth to this concept because there was an intervention, looking at staring at us. We were supposed to give an intervention where baby and mother need to be together for 24 hours. So what do? Either we take the baby to the postal wards or we get the mother to the NICU. These were the only two options. And since NICU is such a technical care and mothers are stable mothers in MNCU, so there was a facility which was created during the trial, which was named as, the name also came very logically. It was an NICU, level 2 NICU. Mothers were brought in, so it was named as Mother NICU. So Mother Newborn Care Unit, the name was given, and it was a 12-bedded unit. And in this unit, all the facilities of level 2 newborn care, it is not an ICU for the mother. Here the mothers are only those who have uneventful vaginal or cesarean, or at least they are not sick or hemodynamically unstable. Those mothers who will be otherwise going to the postnatal wards, only those mothers will be coming to Mother NICU. So it is an ICU for the baby. Along with that, mother is staying 24/7. So all the facilities for level 2 care for the newborn should be there in each cubicle for the baby, just like SNCU, monitor, radiant warmer, oxygen suction, CPAP, phototherapy, and so on. Along with that, an adult bed with adjustable back support and KMC chair for the mother to provide prolonged KMC. So this is how MNCU came into existence through this trial. And obviously, if we want to give KMC for for near 20 hours, we were aiming, and 15 to 20% of these babies had respiratory distress at birth because most of them were preterms, 1 to 1.8 kg. So in respiratory support of CPAP also KMC was provided. And what study achieved was 17 hours of KMC MNCU during that trial. So now, so this was how the study happened. I told you the flow of the intervention cases and the control cases. And then, so you understand the study design and all, how it happened, and then the results, how it happened. So looking at the demographics, if you see, since the babies were 1 to 1.8 kg, mean birth weight of enrolled babies were 1,609 babies in intervention, 1,602 in control babies. I want to tell you one thing, where this trial was supposed to happen with 4,200 babies, but the trial was stopped early at 3211 because of the obvious benefit appearing, and Data Safety Monitoring Board recommended stoppage of the trial because of the very statistically significant results. So mean birth weight was in both the groups was 1.5 kg and gestational age was 32.6 weeks, similar in both the groups. Time to start skin to skin or KMC in intervention, since we started in the delivery area. So the median time of starting was 1.3 hours. But in control, we started KMC when baby was stabilizing and mother started coming inside NICU, and it could happen only median of 53 hours. And then in MNCU, since mother was staying with the baby, 17 hours of KMC babies received. In controls, mothers were encouraged to visit NICU as much as possible, and still we could achieve only 1.5 hours by visiting the mother. And once they were in the KMC ward, both the groups had similar 19 to 20 hours because both the groups were with the mothers in the KMC ward. Primary outcome was mortality, neonatal mortality in first 28 days of life, and RR of 0.75 means there was a 25% reduction in mortality in NCU as compared to NICU, all-cause mortality, total mortality. And death between in the first 72 hours, the mortality again was lesser, but the sample size for that was smaller, and that was p-value of 0.09 only. Two interesting findings. Infections, I'll come to that. As Dr. Amit said, there is a lot of apprehension among the healthcare providers, nurses. We also had the team when the study started that presence of mother may lead to increased infections. She is entering and staying with the baby. So this apprehension people have been having, and we were looking at the sepsis rates in the both, and we just anticipating no increase in sepsis. However, in MNCU there was reduction of sepsis. Rather, contrary to the apprehensions, mortality sepsis actually reduced by 18% in the MNCU group, lesser sepsis. And hypothermia was also lesser, 35%. Many people must be wondering at this time, when the control babies were in radiant warmer, why hypothermia was lesser in the KMC group. So actually at India side, hypothermia difference was, this is the combined data of the 5 countries. At India side, we didn't have much difference in hypothermia in the 2 groups. But this reduction was apparent in the African countries where control babies are kept in wooden cots many times. And so KMC reduced by 35%. So the results were very glaring, and the results were published in 2021 in New England Journal of Medicine for the dissemination and in the public domain. And then this study was covered by National Geographic magazine as Power of Touch next month. This I'm not going to take. Dr. Shashivani has already eased my job. She has told. I just wanted to say that it is not just an emotional concept that the baby and mother should be kept together. There is a lot of science to it, which ma'am has mentioned in so much detail. I just skipped these slides. So what are the opportunities we get when the baby is when there is an MNCU? So what I wanted to say is that many people have this understanding that IKMC is equal to MNCU is equal to zero separation. So actually, led to MNCU, as I told you the whole story, how MNCU was built up and created, and nothing much rocket science in that. It's like any other SNCU with arrangements for the mother there. And but after creation of MNCU, we realized that this was such a low-hanging fruit, which we as pediatricians and neonatologists didn't look at it for years together. IKMC just showed us that picture, and IKMC just one of the benefits of having an MNCU, or the mother stays with the baby. IKMC was just you can say the entry point to make MNCU. So in MNCU terminology also, that zero separation means baby should be staying 24/7. No. Zero separation means that the baby and mother are not separated from each other. They are together with as much IKMC as possible, because the maximum benefit of 0 hours, and rest of it also the mother is around giving her a protection to infection, monitoring, breastfeeding, and so on, staying with the baby. So zero separation is they together with as much as IKMC possible. So as obvious, early exclusive breast milk feeding, I have not shown the results. Trial showed the breast milk feeding rates shoot up when the mother stays with the baby, which is very, very expected. Family-centered, developmentally supportive care. We talk of so many activities for DSC, but unfortunately, our nurses and doctors don't have that much time, as well as orientation to do these frequently. And probably mother staying with her with the baby can provide the best DSC. Mothers monitor the neonates also. once they stay, they definitely look at, and they are better prepared for post-discharge care. You really need not counsel them at the time of discharge. She has learned by seeing and doing. Less anxiety and stress, ma'am has already focused on the maternal benefits. So, and mother changing. Mother is a care provider. She is not only the visitor here. And when mothers stay with the baby, they get involved with the mother baby care, changing diapers, feeding, palliative feeding. Rather, nurses they only train the mothers, and after that, mothers take over this palliative feeding and breastfeeding. And as I discussed, this is much more developmentally supported than our babies lying in the baby mamas alone. A little more about this calculations, which WHO stage group has, translated all these numbers, and they say if we do KMC, depending as the studies have shown, if we do KMC for every baby less than 2.5 kg, the last one, right from the beginning, immediate KMC, then in the during the hospital stay. I'm sorry. During the hospital stay and at home, the community KMC also, if all of these done, the whole continuum of KMC we are able to achieve with 80% coverage. The problem is a lot of interventions known, but the problem is of coverage that we need to achieve. We can say 400,000 babies per year. This also, ma'am has shown that now the guidelines have been changed and immediate KMC is now in the guideline and by the WHO, but that is possible only if we create mother newborn care units, because it is not possible to give long hours of KMC inside the NICUs. Till we have MNCs, yes, we should try hard by getting the mother inside NICU, but our final aim should be to get the MNCs. In concerns, which Dr. Amit also said, that a lot of concerns, it all sounds very good and scientific, but definitely it is very challenging. A lot of challenges need to be met and a lot of concerns have to be taken. So the most important concern is creating mother's bed. So most of the people have a issue that there is a space issue. Now we can have so many babies. The moment we get mother's bed, the number of babies is drastically reduced. I have just one line here to say, because I have a good, those audience which might be looking at this answer. For outborn babies, I understand that presently we are not giving bed, which we should have given to the mother in outborn also. But we have not given, so now it is a problem giving. It's a new thing we need to create. But for inborn babies, mother's bed is already there in the postnatal wards. It is just we have to reorganize our services and make the baby and mother meet. And for that, we need a lot of support from the obstetricians. Then concern of infections, I've already dealt with. Obstetrician concern, my next speaker is just waiting. And this also, Amit just touched that medical legal problems increase accountability of healthcare providers. We are being watched and there will be fights on medical legal issues. First, by experience, inborn unit we started in 2017, 7 years on. Outborn mother NICU, I am running since 23, so almost 2 years. But we are not facing this issue on the practical thing, apprehension, but not practically. It is more a matter of communication. And you have more medical legal problems if something happens in the NICU without mother watching that, and there's a lack of communication. I feel communication is much better and daily and continuous when the mother stays with us. Sepsis, I have told you that the infection rates actually reduce. I'm running, I think, out of time, so I'll skip this. And yes, healthcare providers need training. So these are all challenges to operationalize MNCU and to create MNCU. Getting the binders is a very, very important thing. And implication. So now you need another policy makers. The policy has to be changed, which again is a system change and difficult to achieve. But once it is done, it will revolutionize the way neonatal intensive care is separated. Since today we also talked about zero separation. So zero separation is not something only for the low birth weight babies, and it is not equal to IKMC, as I said. IKMC is only for the babies less than 2.5 kg as recommended. But zero separation is for every baby. At Safdarjung Hospital, we are running a tertiary newborn care unit, mother newborn care unit of tertiary level, outborn, where all babies stay with the mother, including level 3 care, who are ventilated. And you can see in the radiant warmers, term babies who are not candidates for IKMC, but still they are benefiting by staying with the mother. There are a lot of benefits they also get. So zero separation is something for every small and sick newborn, and this is the future we all are looking at, that every baby will be, down the line, every baby will be with the mother, irrespective of weight and sickness. This also Dr. Shashivani ma'am covered, that it has now come into our national program also, so we are set to go. So we, the healthcare providers, we have separated the babies in the NICUs from mothers in the past. Of course, we thought that was the best. We were not, doing it intentionally, any harm to the babies. But after this practice of zero separation, understanding physiology, lot of physiology, and Dr. Shashivani showed how at the molecular level or the tissue level how this zero separation works. I have showed only you the numbers. She has shown you the how it happens at the level of physiology and molecular level. So with this new evidence, now we should all be pledging for zero separation from birth. Thank you. Sorry for overshooting my time.
That was wonderful. Dr. Ruchi Ranavati ma'am is here.
Yeah, yes.
Ma'am, your
I
expert.
think we'll be taking questions at the end. Thank you, Sugandha, for a very informative and telling the audience that how MNICU is possible, how MNCU is possible, and how can we implement KMC and zero separation in our own units. So I think we will, for the want of time, we will take the questions subsequently. But we are more interested in also knowing the obstetrician's perspective, because KMC is not going to be complete in MNCU or in NICU unless we have very supportive group of obstetricians. And I think to address this particular issue, obstetrician's perspective, we have Dr. Jyotsna Suri with us, and I request her to start with her presentation.
So it's a wonderful perinatal unit with the pediatrician and obstetrician sitting close by for the webinar, presenting from the same computer. So that's some teamwork which is there.
Yeah, so good afternoon to everybody. So it was a nice introduction for the obstetrician to come and take over, and Dr. Sugandha has just been commenting that this particular MSA, that brought us closer together for more interactions in a positive way. So is it there? Yeah, I'll share. Yeah, so I'll be briefly talking about the challenges which are faced by the obstetricians, but it's not come. Wait, you have to start now and so on. मैं इसको दे यहाँ पे नहीं I had showed it already. Wait a minute. डबल क्लिक किया था स्टॉप शेयर करके दोबारा कर दे एक बार दोबारा शेयर कर दो एक बार ये हाँ ये हाँ वहां से बोले शेयर करने का Dr. Deborah, we are not able to share. Can you share her slides? We have shared in the morning. I don't know why it is not picking up. Mine will pick up.
Sure.
We'll try once more. Otherwise, then आप कर लीजिए please. ये है ना, there is some problem. कुछ connection activation failed. उधर से हो रहा है. Yeah, उधर से. Thank you. Yeah, thank you so much. Yeah. So when this particular unit was started in our hospital, there were a lot of challenges which we had to face, and I will be talking about them. Yeah, please can you go to the next slide? Yeah. So I've listed these challenges as the bullet points. So first of all, it was initiating the KMC within the liver room, then transportation in the KMC position, creating a mother and baby friendly infrastructure in the NICU, and which is the MCU, then coordination with the pediatric team for continuous couplet care and ongoing training of staff in both obstetrics and pediatrics. So these are all the different challenges. I'll talk about them in the coming slides. So please, can we have the next one? Yeah. So the first one is initiating KMC in the delivery room. So initiation of KMC, the skin-to-skin contact is a regular practice in our labor room. I think most of the labor rooms are following, at least in the tertiary care, medical colleges, everywhere this practice is going on, and the same is in our hospital. But initiating the KMC with the mother or the surrogate, these are different, aspects which are much more challenging. And then, of course, transporting to the mother NICU, this surrogate, this pair of the surrogate or the mother along with the baby. Next, please. Can we have the next slide, please? Yeah. So now initiating the KMC in the delivery room. The particular challenges which we faced, the first thing is, identifying the mother who would be needing that, who would be having the baby who needs immediate KMC. So this mother, it is difficult for us to predict as obstetrician the intervention. But with the help of the pediatricians, our SRs, they all were very, very tuned and all preterm and small for gestational age, FGR babies. So they were constantly, in touch with the pediatric colleagues to discuss about the issue that who are these mothers, because even before the birth of the baby, you need to start counseling them. And because immediately after birth, when you start this KMC, they have to be receptive for it. And if the mother is not able to do the KMC, we also need to have a suitable surrogate who is identified. And this surrogate, of course, has to be culturally, socially acceptable and acceptable to the family also. And the family has to be overall counseled about the benefits of the IKMC and why we want to do it. Then designating the particular KMC area with the bed and the KMC chair in the labor room. So in all busy labor rooms, like especially our hospital, where the space is a very big constraint and are having a huge number of deliveries to the tune of say 70, 75, and in the heavier season it may go up to 85, 90 or even 100 deliveries per day. So it becomes very difficult to have extra space. But out of the existing space, how we made, I would be showing that how we converted a few labor beds into our KMC beds, and then a small area outside the labor room, in the changing room area where the patients change and then come in. So over that area, we had a small area where we could find a good place to put our KMC chairs. So it needed to be, looked into carefully, and we could get the necessary, the space for doing these interventions. Then ensuring the adequate supply of the garments with the binder for providing the safe and effective. So this is again an operational problem that at times we should not go out of stock in the labor room, and the nurses have to be constantly checking it and letting us know that they have enough garments. Next, please. Next slide. Yeah. So these are the, we have some eclampsia beds. The concept is there. So, those particular, we got changed those beds, and also some of the labor tables, the older ones were done away with, and we got these new beds in which we could raise the head by 45-degree or even lower sitting position, so that the mother would be comfortable just after delivery. If she has to initiate the KMC, it was easy for her, and it has the railings which makes it more safe for her to provide the KMC rather than a plain labor table, where the risk of the baby slipping down unless there is somebody holding on, so that becomes a big challenge. So these are much safer for the baby as well as for the mother. Next, please. Next. Yeah, so this is about the transport. These particular pictures have already been shown by Madam previously, Dr. Vani. I was listening to her wonderful talk, and then Dr. Sugandha. So this challenge, actually, from the point of view of obstetrician, it is the infrastructure again here, because then you have to transport a baby with a mother or a surrogate with a mother in the KMC position to the MNCU. You do require extra manpower. So again, from our point of view, in a busy labor room, we do not have that kind of stuff, because once they are assigned this work, it will take them a good hour to go and send the mother carefully, and then transfer her there, and then bring back. So the oxygen cylinder or the CPAP machine, if that is required, that becomes much more complex. So these things, the training is required, plus additional staff is required, which we did have during the time we were conducting the trial. But later on, it becomes, it became more difficult, and definitely the motivation of the staff, the nursing staff, as well as the other staff, is very important if this additional, work has to be done from the away from the, in addition to the routine work. Next, please. Next. Yeah. So another point is that once you are planning the MNCU, try to identify an area which is close to the labor room, because when we are transporting, so the lesser is the distance to be covered, it becomes much easier. There may be a problem of temperature maintenance also. So the third point was about the mother newborn care unit, and how both the mother can get the comforts which she, as a postpartum woman, she herself, for her own needs, she does have need conditions which are suiting her, which are available in the obstetric wards. So Dr. Sugandha has already spoken about those particular facilities which are already there in the MNCA unit. Next, please. Next. Next, please. Yeah, so these pictures have been shown already, how the KMC chair has been placed for the mother's comfort, and how the bed again, she can recline and sit comfortably. So all the things here are there. We have got the panel for oxygen and other things. In case the mother, by chance, sometimes if she requires any such intervention, even though we took care that, always the stable mothers are transferred, and in case the mother is not stable and is sick, then the surrogate is the one who provides the KMC. Next, please. Next. Yeah, this has already been shown. Next, please. Okay, so Dr. Sugandha had not talked about this. So in our particular MNC, we did have a small cubicle for doing the mother's dressing and any small procedures if it is required. And of course, you can see a pantry area and a toilet and bathing room with the geysers. And the pantry was especially found to be very useful when the patient's feedback was taken, because we had some chairs and tables, and the mothers could sit comfortably and interact with each other while having a cup of tea or while taking their meals. Next, please. Yeah. So then, to ensure that the care of mothers is not compromised in essentially a newborn unit, uh, we did develop a essential care package, which the WHO has also used from our side for all the other sites which were doing the trial at that time. And I think the government of India has also made this document now, which is including the essential mother package. So these, because the people who are 24/7 looking after the mothers are the neonatal nurses. So they have to be trained about what all can be the danger signals for the mother when the obstetrician has to be called in. So all these small training sessions had been carried out at that time, and then we had put up all these packages, the protocols, the phone numbers of the team, duty doctors. Every month the roster used to be sent that who has to be called in case of an emergency. Next, please. Yeah, so these are all about after vaginal delivery and after cesarean section, how many times you have to monitor the mother, what all has to be seen. So absolutely simple things which our nursing staff could easily understand, and they were trained about this. Next, please. Then continuing couplet care. So many a time we would try to, do the rounds as a team so that we could see the progress of the baby, and the pediatrician could discuss about any issues going, with the mother. So this would give us so much more information. It used to be very fruitful. All have, or anybody planning to have MNCUs, you could plan, your daily rounds at a similar time so that the interaction is there between the two teams. Next, please. Ongoing training. So this again is very important because most of the resident staff, they are, they keep going, when they pass out, the SRs will finish their tenure, and then new JRs keep coming. So we need to have on a regular basis the training about this particular, from the obstetrician point of view, it's very important, and from the pediatric point of view about the requirements for the postpartum woman. So these are all trainings are essential and a part of the MNCU. So that schedule can be fixed by both the units, whether it is 6 monthly or whether it is every monthly. If you have new staff coming in every month, or whenever there are new staff, or even as a refresher training every year for the regular staff. Next, please. Yeah, so one of the major challenges is, the cesarean mothers, wherein it is not very easy to bring them within the MVCU as fast as the postnatal unit. So this is a continuing challenge, of course, and again with the help of the obstetricians, uh, telling all the resident doctors that it is okay, you can, send the mother there. There are people there to monitor her, don't worry. Unless the mother is having some other serious issues, like she's having very high BP or something. So after 8 to 10 hours of observation in the post-operative room, we would encourage that all the cesarean mothers should also be sent for the KMC. So this is, of course, something which we still are, we have to work upon so that we could get them earlier into the KMC, the MNC. Yeah. Next, please. So this is about what I was saying. To surrogate inside the OT, we would be, ensuring that a similar KMC chair was there and transferring mother to the MNCU as fast as possible, making her comfortable for doing the KMC. And of course, in such cases, we do need to always have one person who is the surrogate who can give the KMC to the baby when the mother is tired and also look after the mother because the mother after the just on the first day of the cesarean, she does need somebody to look after her needs also. So this is, I think, very important here in this case to have a reliable surrogate. Next, please. So the last slide is that I think most important that strong cooperation, coordination, and collaboration between the pediatricians and obstetrician is the cornerstone for the successful development of the MNC. So without that, it is not going to be easy to initiate or to continue the services as a team. So thank you very much for giving me this opportunity. I'm grateful to the organizers of this session. Thank you.
Dr. Jyotsna, it was really enlightening to hear, especially about the surrogate KMC mothers. And this was something I heard for the first time. Welcome, Dr. Harish Chilani, sir. So it is so nice to see you, one of the art teachers and one of the pioneers in KMC, IKMC, MNCU in India. Welcome, Dr. Chilani. So,
Thank you, Dr.
your
Amit.
comments on-
Sorry, I was busy in the ICMR meeting. So
Yes, sir.
thank you.
Yes.
Thank you very much.
Good afternoon, sir.
Hi, Dr. Jyotsna. Wonderful to see both of you together. Right kind of signal which is going on, as Amit said earlier.
It's your legacy, I said.
Yes. Thank you. Thank you. And hello, ma'am, Dr. Shashivani, ma'am. Good afternoon.
Hello. Good
Dr.
afternoon.
Ruchi, Dr. Kumuda. Nice to see you, ma'am.
Good afternoon, sir.
Yeah, thank you, Josna, for that wonderful talk. And at the end, I like that your, cooperation, coordination, and collaboration amongst the pediatricians and obstetricians. And I hope that this thing exists in all the unit across the country, and then we'll be able to implement IKMC in almost all the centers. So with that, I think now we invite Dr. Kumuda, again, a person who has worked, lots in the private sector in government medical college. Now she's a dean of Savita Medical College. So she's the right person to tell us that we have learned the science of KMC. We have learned also the evidence base of KMC from pediatricians perspective, from obstetricians perspective. Now, how to operationalize this and how do you implement KMC? I think Kumuda is the right person to tell us, and I request Kumuda to take over.
Thank you, Dr. Ruchi. I don't know whether I am the right person. We are trying to do something in Tamil Nadu and especially our unit. Can you share the slide, please? Or do you want me to share? Thank you. Can I have the next slide? We know that evidence is there. IKMC in India has shown, and Sashivani madam in a lot of her community studies and studies in Ahmedabad has shown that zero separation is the answer. No, we know that even though the child is a preterm or a low birth weight who needs KMC, may have certain handicaps, but has perfectly wired and competent brain for extrauterine life. But what we have to do is the epigenetics. Epigenetics is what the mother can give on constant and uninterrupted physical presence is required in skin to skin contact. So this is what we are going to do, the epigenetics, that is both KMC nutrition and nurturing care, which I don't think any machine or mechanics or highly expertise neonatologists can provide. I think, first of all, we have to realize this fact before we practice zero separation in our hospitals or in our settings. Next slide, please. Again, critical period. Once again, I want to reiterate what everyone has told, that at birth, the child is the most alert one. You know that noradrenaline is 10 times higher, and whatever stimulation we make on that side, on all the five senses, is going to stimulate the amygdala and go to the frontal lobe and has a memory, which goes a very, very long care in the start of the developmentally supported care. So there is no other question of taking the baby elsewhere other than with the mother. So this is one concept for zero separation is a foundation what we have to start at birth. Next slide, please. So we have to have not a very crying baby like this, but we have to have a baby who's in skin to skin contact with the mother soon after birth. Even swaddling, everybody thinks, okay, I can comfort the baby. All this only produces fear and terror, in contrast to the regulation we are going to produce, which Madam really beautifully brought out in our slides. Next. But what is the current status? See, we have institutional deliveries, especially more than 95% across India, and Tamil Nadu state boasts 99.6%. And we have SNCUs across the country more than 1,000. In fact, 1,094 SNCUs, and many of the medical colleges are now having NICUs. But what do? We get the baby out, cut the cord, put the baby in a warmer, and then we do all our ministrations other than looking after the baby. That is what we say. The excuses or the explanations we give for that is inadequate staff, and we are not at all syncing with the current evidence. See, evidence has shown, especially from Safdarjung, that zero separation is the answer and the key for even critical and sick babies. And we are very, very afraid to include the family in any of the things. It should start from labor room. But how many labor rooms across the country do have a birth companion along with their mother? This is one question which all the obstetricians and pediatricians have to answer. And we always say that we have to have a liaison with the OBG. We do have. That is why we have progressed so much. But I think our liaison has to still continue, and it should be taken to greater heights. I'm very happy Dr. Jyotsna said, told that it was not rosy, but it all had the hurdles which had to be overcome. And also we need a lot of admin support also for this. If we start something and they will say this baby became sick only because somebody gave the baby to the mother, otherwise this baby should have been monitored. So many other issues do crop in. And even if we start sustainability, see, we start, that is our experience. We think we have put all the things in place, and suddenly we will go back to their old methods and then have the separation. So that is another thing. And monitoring and support. As Dr. Sachivani always says, we should monitor across the country how many institutions are following the zero separation, both in the labor room and in the postnatal and NICU wards. So unless we do all these things, I don't think we would be able to implement successfully. We are implementing partly or partially at various levels, but the adequate coverage of 90% and more, we have a long way to go. Next slide, please. So, in fact, we started our thing modifying our labor room itself. We had the labor boards, even in a private medical college, but now we have changed it. We have brought in all the Lakshya principles and made these beds which are much more comfortable for the mothers, and to have some respectful delivery room, and also to initiate KMC or skin to skin contact, not only for sick babies, but also for well babies. Next. So this is what currently we are doing. And I would say this at the labor room practice for all the babies who are stable, it is more than 90%. Or I would say nearly 95%. So skin to skin contact and early initiation, and also our achieving of continued skin to skin contact for at least 1 hour. So this is a practice which we have tried, and we have done a lot of quality initiatives, and we have achieved in more than 90% of the babies, in stable babies. Next. And so our journey on mother and newborn care unit commencement started on 18th November 2024 with 4 beds. And it was inaugurated, I'm very proud to say, by none other than Dr. V.K. Paul sir and Dr. Raju Behel from ICMR, who are the eminent members who have been working there all their life for the care of their newborn. Next. So this is our MNCU at Savita Hospital. We have currently 4 beds in this. You can see a man there. So we do allow even fathers right from the beginning, if the mother cannot be transported, as Dr. Jotna said, to give the KMC care in the MNC. Next. Next. So this is a single bed with all the warmers where we can give even we have moved in currently even 1 ventilator. So we can do even a level 3 care in this MNC ward. But currently we are giving level 2 care. Next. So our unit data for the past 5 months, the couplets treated were 196, and on average we get 40 babies couplets, and mostly they consist of preterm babies, low birth weight babies, babies with respiratory distress at birth, and jaundice. In fact, we have now added all postnatal admissions to NICU, also straight to MNCU along with the mother. And also babies who need certain workup have gone to postnatal ward, like evaluation for cardiac disease and all that is now done from MNCU. So our unit NICU strength has gone down because we have got more patients in the MNC. Next. And this is how the father being assisted by the nurse there. And this is our entry point. Next. Next. And our small storeroom, and this is the entrance for the mother's toilet and the restroom and necessities. Next. So the process started with convincing the administration. First, they said you have an NICU and you have a KMC ward. Why do you need another MNCU? Why, with the amount of patients we do have, why do you need MNCU? So that needed a lot of convincing. And we had a location, as Dr. Jyotsna said, in the same floor. We are just close next door to labor room. Our NICU is next door to labor room, and this MNCU is just next to that. And identification of space, though we would have liked for at least 10 bedded unit, we got 4 bedded where I could space in 5, but comfortably we can house 4. And we needed lot of obstetric license. Still we have problems in shifting mothers as early as we would expect. So there are problems like watching for postpartum hemorrhage, mothers with hypertension, mothers who had all the high risk factors. So those are still our constraints. And human resource allocation. Actually, we convince administration that lesser nurse ratio could be maintained in MMC ward because the mother or the attender is there. But anyhow, we have now 1:3 allocation there. And we had to do a lot of family counseling for recruiting the surrogate persons for KMC and staying in the MNC. Next. So first we had to address their fears, doubts, and a lot of myths also had to be taken care of. Always they thought baby in a glass room is much more kept, sick baby can be looked after than in this ward which has an access, because they all dig into their brain that NICU care is better than MNCU care. So all that had to be addressed, and then reassure about the KMC, safety of the KMC in a sick baby. That is another thing we had to really allay their anxiety. And especially they were accepting mothers giving it, but they were very apprehensive of a surrogate person providing KMC. And so we encourage shared caregiving and also a lot of peer counselor, those who were in NICU, that is surrogate people who had given KMC, we used them to convince these people to come to MNCU and give. So this gap between the healthcare providers and families really narrowed. As Dr. Sudanta said, we used to do a lot of pre-discharge counseling. But after MNCU, the parents were well versed by the time they were fit for discharge. They had less doubts and they were much more confident of taking care of the baby at home. And not only that, they were very confident of continuing the KMC at home because they said, even if the mother is occupied, we would be there as a family to support the baby by providing KMC. So that was the assurance given by the parents at the time of discharge. Next. And of course, we concentrated on education of the families. Always we did not teach the mother alone, always the family, at least 2 members were included in the family counseling, infection prevention, importance of KMC, techniques of KMC, skin to skin positioning, and breastfeeding support. We had this DPH handouts. We used whatever the government had done. We did not make any new ones, KMC Foundation ones. We used what the Tamil ones of the government we used for educating them. And developmentally supportive care and monitoring signs of distress. All these were the points on which they were taught. Next. And then challenges were resistance from healthcare providers. In fact, we had difficulty in convincing our own faculty, our own health staff. They had a lot of apprehension. What will happen, madam? Even people who have visited Safdarjung Hospital, they did it as a project mode, madam. We are doing it as an implementation. We don't have a project person to look after the things. And all those things were the concerns, but eventually we could dispel them. And initially in the first month, we had only 10-20 babies there. But currently we are having 40. And last month, in fact, we had 53 couplets there. And privacy concerns, whenever we had added men, they were there. Of course, curtains were there. And mothers also became then much more confident in giving in presence of the male attenders. And continued training was a challenge. We had attrition of certain staff nurses. Then we had to give training. And again, our postgraduates used to come, especially pediatric, come in rotation. And so they had to be continuously trained. And again, that is a continuous process, as Dr. Jyotsna said, which we have to continue to do. Next. And the perceived benefits of MNCU by the mothers, and they felt they were active caregivers. They said like some of the mothers had their previous baby admitted in NICU. So when we asked them what is the comparison between the NICU care and the MNCU, they said always we were not inclusive in NICU care. We were always visiting the place as a visitor rather than a caregiver. Now we feel we are active care providers and we can really take care of the baby. That is one thing. And they felt they were given personalized care. In fact, it was an AC cubicle, AC room. So they were very happy that they had a temperature adjusted room, especially in this April, May and all. They are very happy. In fact, they were not willing to go home. They said, you can keep us 1 or 2 days extra also. We don't mind staying here. So that was the comfort level, not only AC, I know. It is the other things like personalized care by the nurse. Nurse were able to spend more time because by the time they were ready to give the care, they did most of the work. And nurse was there to only to monitor and supervise them. And so they were very happy. Next slide, please. Next. And also the strong collaboration between pediatrics and obstetric department. I'm very happy the same words Jyotsna said we did have. And we found once this was the mother put the baby onto her chest, she was very calm and she was very responsive. And also, the postpartum psychosis or behavior problems, we did not see much. Earlier in NICU babies, we used to have a lot of tantrums in mothers. At one time, they will be very nice. At one time, they will be very depressed, crying. And one time, they will be very angry with the nurse, as saying that she did not do that and all. So that sort of behavior we did not see in MNCU mothers at all. And they were able to understand the cues better because they were with the baby all the time. They knew when the baby wanted to feed. They will say, take the baby and feed. No, no, my baby is not wanting feed. They want to be there only. So those sort of understanding the baby's cues and the emotional bonding of these mothers was ultimate. They were ultimate in being bonded with the babies, and the babies too also were serene, and they had very good sleep, which madam said, like uninterrupted sleep, active, that quiet sleep also was longer hours in these babies. Next. And as far as immediate skin to skin contact, we were able to get much earlier. And again, early initiation of breastfeeding, especially suck feeds, we were able to get. We are documenting the data because the data is not complete. I have not shared it. And we did not have any infection in any of these feeds, not even one baby. And better sleep. They had a shortened duration of hospital stay. And KMC hours on average, we were able to get 14 hours per day. And we were also learning the technique of giving KMC for phototherapy babies because we shifted all phototherapy babies there while they were feeding and they stayed there for longer hours. And then they put, and there was no problem in reduction of bilirubin also. So this is one area which Madam Sashivani has been asking us to practice, which now we are able to do that. Next slide, please. And we have another KMC ward, which I told you earlier. Again, we are planning to convert this also into MNCU so that we get more beds for MNCU. Next. And then in implementation in Tamil Nadu, if you look at, we have currently in IOG, MNCU 20, and I think Dr. Mangalabharti has increased the number of beds also, and it is functioning right now. And there are 4 MNCUs are in pipeline waiting to be inaugurated, all set up in other 4 medical colleges, and 2 are approved in the current PIP. So we will have soon 7 MNCUs. And all those MNCUs are planned for 20 bedded units in Tamil Nadu. Next. So the way forward would be operationalization has to be a continuous process. There's no point in having only one Saptajang as an example. We have to show other places, and I think all the medical colleges, teaching hospitals should set an example and say, it is possible. Maybe they can, like us, many people might say you got only 4 beds. But I'm happy with those 4 beds and the mothers are happy. This is what I want to convey here. And soon, this conviction has allowed my administration to think of extending it to the other KMC ward also. So if we quote this and share this experience, I think lot of people would take it up. I feel it is because of the fear and anxiety whether they could implement it successfully is a concern I think we have to do. And again, Ministry of Health has rightly given the implementation guidelines that new SNCUs should be started as MNCU rather than SNCU. And again, they've also given a directive to convert the KMC wards into MNCUs. So that also would go into from the existing thing. We could easily implement this across the country because we have NBSUs also lots. And we have SNCUs more than thousands across the country. And they also have many of the medical colleges attached KMC wards. If those are converted, then easily we can practice. And of course, outcome measurement. As of now, we are not measuring the zero separation in any of our survey data, NFHS and all that. So we should see how much is the skin to skin, whether it is being practiced, that's all. The coverage nobody is measuring. And dissemination, like what Sabdacham is doing, disseminated is across. See, I heard Sugantha and Dr. Harish sir talking in various fora for so many days. Yet still we are talking and our numbers are not increasing. I think we should continue this intensely and maybe monitoring and certification. Like SNCU certification, we should also have MNCU certification. That would also go a long way in implementing our zero separation, not only for sick and small babies, but also that will have the ripple effect for all the postnatal babies. And nowadays, now we are all the less than 2.5 and less than 37 weeks who's gone to the postnatal ward or all in KMC in postnatal ward. So that ripple effect will go everywhere and zero separation would continue. And hopefully this will also continue at home at the community. I think that's the last, right? Next slide, please. Next slide. I think togetherness is always, as Madam said, that we do not have any business to separate the baby and the mother for saying various other reasons. Whether they are sick, whether they are healthy, they have to be together. And of course, we would be there to help them if they are sick, but they have to be together as soon as possible and as early as possible so that we do the best outcome for our all the babies born in our country. Thank you.
Thank you, ma'am. Thank you for the excellent talk. So much is happening for KMC, IKMC, MNCU. So we can have any comments from our experts or any questions from the participants.
I just want to, I think the first preference should be for the questions. As Dr. Kumita ma'am said, we should add it to accreditation of the SNCUs as one of the components of this. I feel somewhere the law also, it should be a legal right of the mother and baby to be together. Somewhere we need to legalize this also at some point of time. That is what I just wanted to add.
NNF should take over the responsibility of promoting MNCU, collecting the data, and also propagating it, giving some appreciation to the units who are doing this successfully, and find out different ways and upgrading the accreditation points and several things. And continue with such seminars in future also. Not just do one seminar and leave it for the year. Have some continued sustained activity so that that concept is strengthened amongst the members.
Definitely, ma'am.
Yeah.
Amit, can
Amit, we can have KMC friendly units.
Definitely.
It need not be a part of the entire accreditation guidelines. It should be specific that we are talking of KMC and IKMC, and these are KMC friendly units. The NNF can give them the tag for that KMC implementation, what is done.
Yes, ma'am.
Have a separate committee for
Separate committee. Yeah.
Kangaroo mother care. Different aspects.
Committee would be looking at, ma'am, if you can give some detail, we can work on it. So committee.
Training, surveys, accreditation points, sharing the information regarding the various equipment which are required or any other things. There are so many, means a lot of scope.
We can add on to that, to our accreditation committee, we can add on KMC wing to it.
Yes.
So.
Dr. Amit, I recently went for accreditation. In that, there are no points for zero separation and things like that. Maybe we can add in that accreditation.
Yes. Initially, maybe just at least to begin with, there could be, you know, a place for designated place or inside the NICU itself for doing KMC for long hours, and zero separation maybe
Subsequently.
it will take some time, at least in private hospitals, to come over.
And at academic level, forming the proper definitions.
Being in private now, I'm saying if they get convinced, they will do it very fast.
Yeah.
Yes, ma'am.
So start acknowledging the units who are doing it.
Yes, definitely.
So that will also give some incentive.
Definitely.
And promote some multicentric research studies which are relevant to our needs. And also, there is a strong need for standardizing the definitions and nomenclatures. Now that the concept is spreading everywhere, there are a lot of misconceptions and misnomers. Each one is using their own nomenclature. All that, now the time is ripe.
Yes, ma'am. We can have that. NNF can definitely do it as a low-hanging fruit. Have a committee which comes up with standardized definitions and guidelines, and that will be something which is publishable as well. And
Yeah.
this
And
will
one more area is KMC transport to be included and upgraded in our guidelines of neonatal transport.
transport.
Yeah, and
So
Amit,
is
one
there?
suggestion,
Yes, ma'am.
one suggestion that our NNF conference, we can, acknowledge or felicitate the units which have started MNCU and implement IKMC. So that can be sort of, the something like stimulation for the other units to do it. So they require a special acknowledgement.
Definitely, ma'am.
Yeah.
This can be done from this year itself.
Yeah, this year itself.
Yes.
And Amit, as you and Dr. Kubada also said, it's an effort is first to keep the mom and the baby together. I mean, being it at a birthplace or during the transport or during, because sometimes the people they feel that immediate KMC is not possible. That is within the first 2 hours. I say at least you keep the mother and baby together. First, start with those babies where you are comfortable. That is those low birth weight babies who do not require respiratory support, but we are keeping them in the SNCU for assisted feeding. Why can't these babies be put on straightway onto the mom's chest? That is the first thing. Then there are another significant number of babies who require respiratory support or oxygen support just for 24 to 36 hours. Believe me, that is the next group which we should go upon. Third is when you are confident, you can take even the CPAP also. And as now the Dr. Sugandha's unit, even non-invasive ventilation, where the interface is the same as the CPAP. So the unit confidence has come and now they are doing it. So just keeping them together, and I feel KMC should not be taken as a vertical intervention. It is a package of intervention. Along with that, moment you keep the baby onto the mom's chest, the breast milk will be available and early breast milk feeding will be encouraged. And then, of course, with antenatal corticosteroid, respiratory support, these are the 4 key intervention where we should make an dent actually for the care of small and sick baby. And I was looking at this, Donald Wincott in 1832 mentioned that there is no such thing that there is a baby. There is always someone with the baby. And who is that someone is the mom actually. So I think whenever we talk about a baby and the mom, so mother baby diet has to be and together. And as Dr. Sugandha also mentioned in the last slide, till now we had been doing best, whatever the evidence was there. But now the time has come, and I still acknowledge the efforts of the DGICMR and the group who worked on that. Because evidence we completed trial in 20. 21 publication came. 22 November the guidelines were revised. So we have achieved a lot, but I think now, as I mentioned in the chat box, seeing is believing. So whatever the units are there, they should start, call the other people. Once they see that, and MP has taken a great initiative, and they are now implementing this. The Gandhi Medical College, I have seen wonderful unit actually they have got, and they are now starting. Similarly, Bihar, and as Dr. Kumuda mentions, the all the medical colleges. So I'm sure this transformation is going to happen. And Amit, you are going to take the lead in your tenure to take it forward. This is another challenge Madam Shashivani is posing to you.
Yes, definitely. Definitely, sir.
Yeah.
And coordination with other professional organizations. Foxy, IAP, from foundation level, we have been trying a lot. But if NNF comes in the forum, it will create a big impact.
Definitely, ma'am.
So even
Just
the
keep
community
guiding us and we'll
pediatric
be
chapters, there
active.
are so many things you can do, endless. Nursing chapters.
We'll
and
be
so-
your foot soldiers
Yeah.
and you just command from your place and we will try to implement things.
Really, I'm really glad that now people have started giving attention to this topic and realizing its importance. And
Yes.
once again, I'm saying we are not talking about KMC as a vertical program. It is an important core intervention of the newborn care, and it includes promotion of breast milk feeding also. So it is not separate. That's why I wanted the definitions to be clear, so many other parts to be, the fundamentals have to be very clear. Still people are mixing up with the names and the definitions and all the nomenclatures. So now at least the time has come that we should sort out all those things. And
Taking it
is
as
the
a
right
standard
place.
of care, actually.
Yeah.
Yeah.
And acknowledge whatever the efforts are being done by the individual organizations who are trying to promote KMC, including several NGOs are now doing in the community level also. So if NNF takes it over, it will really have a multiple rippling effect. Thank you. And we won't go for a long time.
Thank you, ma'am. Thank you, sir. Thank you, Dr. Kumada, Dr. Ruchi Nanavati, ma'am. She was also very busy with the meetings. And Dr. Shashivani is already in Punjab doing a KMC workshop there, ma'am.
Yes.
And so she's
Today
such
we
a
have
big proponent of
simultaneous.
KMC all over the country and even abroad. And ma'am, your efforts are really commendable. Your energy is infectious. So can we break, sir, now with your permission?
Yeah. Thank you. Thank you, everyone.
Thank you, everyone. Ma'am, next, whenever you say to have a good webinar on KMC, we can have one.
Thank you.
Okay, ma'am. Thank you, ma'am. Thank you, sir. Okay.
Thank you. Thank you, Dr. Ruchi. Yeah.
Yeah, thank you, all of you. It was a great session.
Happy
Really enjoyed.
KMC Day to everybody and let all units be a hot seat for KMC in their NICUs.
Yeah.
Thank you, Ruchi, Kumuda, Dr. Suri, and of course, Dr. Sugandha for joining in the last minute, but making it a grand success. We didn't have any doubt about it, but just for the cause of it, all of you joined together. Thank you.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Thank you.